Alrighty, let's talk about the infection chapter of the Absite review. First of all, it starts with an introduction, which is malnutrition is the most common immune deficiency um, that leads to infections, right? So I guess it makes sense, malnutrition, okay? And then you talk about the microflora. So what is microflora? Microflora is basically literally the normal bacteria slash like living organisms, the micro living organisms that are in your body that are okay for them to be there. They're not like an infection or something. Like we have bacteria in our guts, we have bacteria on our skin, we have all sorts of these things, right? And these are called the microflora or the normal flora. All right. And when you talk about the stomach, it's virtually sterile. But you have some yeast, not important. The proximal small bowel has some bacteria. The distal small bowel has some bacteria. Where you get to the important part is when you look at the colon, right? The colon has a lot of bacteria, but almost all are anaerobic bacteria. And then you have some gram-negative rods, and you have gram-positive cocci and all that stuff. Doesn't matter. Focus on the colon having almost exclusively anaerobic bacteria, right? And the most common anaerobic bacteria is Bacteroides fragilis. So B. fragilis is the most common anaerobic bacteria in the colon. And remember how the colon has a little bit of gram-negative rods and like gram-positive cocci, but gram-negative rods mostly. The most common aerobic, these are aerobes, right? The most common aerobic bacteria in the colon is E. coli. Right. So when you get an infection or whenever you get something that has to do with that, and you have to, like, we'll talk about the like how you can use this information. But think B. fragilis and E. coli mostly for the colon. B if it's anaerobic and E if it's aerobic. And then you talk about fever, right? So it's very important to know the most common causes for things in surgery overall, right? And then you talk about fever, post-op fever, more specifically. So you have the operation, and then you have two benchmarks, really. And then you have two benchmarks after it. You have the 48 hours and you have the 5 days, all right? So let's just put the post-op as 0, and then you have 48 hours and you have 5 days. If a patient gets fever from the time of the operation all the way until 48 hours, the most common cause is atelectasis. Atelectasis is basically when the airways collapse, right? So you have airway collapse. That is the most common cause of post-op fever in the first 48 hours. And then you have the second benchmark, which is 5 days. From 48 hours to 5 days, the most common cause of post-op fever is UTIs, right? And that could be from an indwelling Foley's catheter or anything of the sort, right? So you have 0 to 48, 48 to 5 days, we said atelectasis and we said UTIs, respectively. And then after 5 days. So what's after 5 days? After 5 days is basically wound infection. So if a question comes and it's like, 36 hours after after an operation, the patient presents with a fever, blah, 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 and then they give you some sort of like, I don't know what the hell, and then they're like, what would you test for, right? After 36 hours is not 48 hours. So most likely this is going to be atelectasis. So I'm going to, I don't know, do an x-ray, do anything that has to do with the lungs, basically. Whatever option they say for the lungs, I'm going to do that, right? If it's after 48 hours, less than 5 days, I'm going to do probably a urinalysis, right? Or urinalysis and urine culture and all that stuff. After 48 hours, I'm going to look at the wound itself. All right. And other causes are pneumonia, DVTs, and intra-abdominal abscess. All right, and now we get to the micro part of it. And I remember when I studied for step 1, I barely studied micro. So I like the way this book explains the micro, because it's very simple, straight to the point, exactly what you need to know, instead of all that stupid stuff that you don't really need to know, at least for your life. I don't know if you're a micro geek. Anyways, so we talk about gram-negative sepsis. So E. coli is the most common, all right? Gram-negative rod. And then you look at the endotoxin, it's lipid A, and then it releases TNF-alpha. The only thing you should know about it is lipid A and TNF-alpha. Don't get too much into like, endotoxin released and the triggers the release of TNF-alpha and all that stuff. Just know lipid A releases TNF-alpha, and TNF-alpha is a very potent stimulus for macrophages and other inflammation in general, right? Okay. And then you have one weird take on how insulin and glucose are related to each other in the case of sepsis. So if it's early gram-negative sepsis, the insulin is going to be low, right? And then the glucose is going to be high, which means there's impaired utilization. Because what makes your body utilize glucose? It's the insulin, because the insulin gets the glucose into the cells. So if you have low insulin but high glucose obviously because it's sepsis and this is a very like a hypermetabolic state. If you have low insulin and then high glucose, makes sense, right? But the late gram-negative sepsis is where it's kind of weird, right? Because you have high glucose, but you also have high insulin. How can you have high glucose and high insulin? Well, according to this book, it says it's secondary to insulin resistance. So basically, the body after a while starts becoming insulin resistant, which means even if the body increases insulin, or if you give the patient insulin, the cells are resistant to insulin, so they're not gonna take up the glucose upon the insulin's command. And hyperglycemia is obviously like very important to look at in terms of gram-negative sepsis because of two things actually. First of all, it often occurs just before the patient becomes clinically septic. So this is a very good sign if you keep doing routine glucose checks. Which I don't know what are the indications for that, to be completely honest with you. But if you, for example, randomly take a glucose check and the patient is hyperglycemic post-op, there's a very good chance he could be going into sepsis very, very soon before any other symptoms show. So that's a very important fact. And if the patient is septic, you want to keep the glucose level less than 180 milligrams per deciliter. So less than 180 is optimal for septic patients. All right. So you give let's just say you're a bad doctor and you give a lot of antibiotics to your patient. Or let's just say the patient is a nursing home or an ICU patient and they're just receiving a shit ton of stuff, right? So they're at risk for something called C. diff colitis, pseudomembranous colitis, which is basically just like C. diff infection. And C. diff thrives when you give too many antibiotics. It kills off most of the microflora, most of the normal flora really in the GI system, and it gives rise to C. diff, which just like takes the throne easily because you helped it, right? And the problem with C. diff is that it causes foul-smelling diarrhea, right? And the way and besides that, it can progress and into fulminant pseudomembranous colitis, which is basically like severe sepsis and possible perforation. And in that case, the only thing you can do is colectomy. So you're gonna remove the colon, part of the colon that has the problem in it. And you're gonna do an ileostomy, which is basically an opening from the ileum to the abdominal wall, which the patient uses for defecation, which isn't very optimal. All right, so how do you diagnose this in the first place, right? You can either do an ELISA scan for a toxin A. So remember how endotoxin, lipid A, and TNF alpha is for gram-negative rods, most commonly E. coli. C. diff has also toxin A as well, not lipid A, toxin A. And usually, besides the toxin A, there's the elevated white blood cells. So how do you go about approaching the treatment for this patient, right? So first of all, you're going to start with oral vancomycin or metronidazole, which the book here calls Flagyl, which is Flagyl, but let's just stick to metronidazole. The reason oral vancomycin is also good for pregnant women is that it has little to no systemic absorption, which means literally it's only going to affect the parts that it's going to go through. It's not going to be absorbed by the blood, which means it's going to stay in the stomach or in the GI system. So you want to give pregnant women oral vancomycin. You also want to give regular patients oral vancomycin or Flagyl or metronidazole. But a second-line treatment for it, or obviously depending on how bad it is the case, you might have to give IV metronidazole. And another, I'm not going to say a third line, but I'm going to say a neoadjuvant treatment or medication or something you can give is lactobacillus. It can also help, right? So besides giving antibiotics and besides doing the total abdominal colectomy with ileostomy in the case of the fulminant, in regular cases, you do need to resuscitate a lot with fluids, right? So also stop the antibiotics you were giving previously, or change them at least, and you need to fluid resuscitate this patient. So fluid resuscitation, oral vancomycin or metro, and in the case of fulminant, you want to do a total abdominal colectomy with ileostomy. All right. So we said when we were talking about post-op fever, besides the main causes of atelectasis, UTI, and wound infection, there is intra-abdominal abscess, right? And abscesses are very important because they're very common in surgery. So 90% of abdominal abscesses have anaerobic bacteria, and 80% have both anaerobic and aerobic bacteria, right? Which are arbitrary numbers, not really important, but it's good for you to memorize. So 90% have anaerobes, 80% have both anaerobes and aerobic bacteria. All right. So abscesses that are treated, abscesses are usually treated by drainage. It could be percutaneous in some cases, and they usually occur 7 to 10 days after operation, right? So let's just add this to the list of like the timeline. Not really the most common cause, keep in mind. After 5 days, the most common cause is wound infection, but from 7 to 10 days, a good cause could be abscesses, but still the most common cause is still wound infection, all right? So don't get that mixed up, all right? And then you have the antibiotics for an abscess, and the reason you would give antibiotics for an abscess, besides obviously just to be completely fair, prophylactically / like when you want to give treatment, because abscesses are fine. Like, why do you want to give a systemic antibiotic, something that is localized? But in some cases, it's important to realize the prophylactic need for that. And these cases are obvious, like diabetes, cellulitis, clinical signs of sepsis or fever, or bioprosthetic hardware. All right. So think about it this way. Diabetes makes sense because patients with diabetes have very poor wound healing, very poor immune system. All right. Cellulitis is almost the same thing. And then you have clinical sepsis and fever. And there's no sepsis without fever. So like obviously sepsis and fever. And bioprosthetic hardware. So bioprosthetic hardware like mechanical valves and hip replacements and all that stuff have a higher likelihood chance of being infected. For example, if you want to go to a dentist and you've had a mechanical valve, that is an indication for a mechanical valve in the heart placed. That is an indication for antibiotics. So imagine if there's like an abscess, not just like going to a dentist. All right. Wound infections and surgical site infections. 2%, they're classified into different like categories. Not really that important for you to clearly know exactly, but just know that there's clean contaminated, there's contaminated, and there's gross contaminated. Makes sense. Clean contaminated, gross contaminated. Clean are like hernias, right? Clean contaminated are like elective colon resections, but how elective colon resections? With prepped bowel. If the bowel is prepped and it's cleaned properly, this is a clean contaminated, right? Still could be contaminated, but it has been cleaned. A proper contaminated is just like a shit show, right? It's a gunshot wound to the colon with repair, right? And then there's a gross contamination, obviously, which is abscess. Because abscess is literally, this is a pure bacteria and pus, right? So that's a gross contamination. Also very gross, not really. But yeah, anyways. Prophylactic antibiotics are given to prevent surgical site infections, and you usually give the antibiotics for 1 hour within the incision. This is usually the anesthesia that does this, but you can also, like as a surgeon, need to know this. So 1 hour after you make the incision, even if you're still in the surgery, you need to give antibiotics, and you stop those antibiotics only 24 hours after the end of the surgery, right? Except in the case of cardiac surgery, in that case, you want to stop it after 48 hours. All right, and then you have Staph aureus. Staph aureus is coagulase positive, catalase positive also, for the sake of that, and it's the most common organism overall in surgical site infections. So when you want to think about surgical site infections, you want to think about two things. You want to think about a coagulase negative and coagulase positive staph. So there's Staph aureus and there's Staph epidermidis. Staph epidermidis is literally on the epidermis, right? So you will think about it, it's the first thing, but not really. It's Staph aureus and then Staph epidermidis, right? And E. coli is the most common gram-negative rod, and B. fragilis is the most common surgical site wound infection for anaerobic bacteria. So you have, in general, surgical sites is Staph aureus. Epidermis is right up there with Staph aureus. E. coli is the most common gram-negative rod, and B. fragilis is the most common anaerobic bacteria. All right, so recovery from tissue, if you recover B. fragilis from tissues, it usually indicates necrosis or an abscess, because B. fragilis is anaerobic, which means it cannot survive. It's not like the optimal environment for it is not a high oxygen state. So if there's low oxygen state, in some cases of necrosis or abscesses, that's when B. fragilis just really grows, and that's when you can recover it from the tissue, and they're like, that's an indication there's necrosis or abscess. Also, there's, like, since B. fragilis is in the colon, how did it get to any other surgical site? Probably means there's translocation from the gut, right? Because that's where it is. It's not going to come from, like, the surgical tools itself, or S. aureus, like it's found everywhere, right? The risk factors for wound infection are just make sense, right? You have a long operation. You have a long age, advanced age. You have a long disease, chronic disease. And then you have a hematoma, a seroma, malnutrition, and immunosuppressive drugs. So when you want to think about risk factors for wound infection, it's a long operation, a long age, he's living for a long time, and a long disease, like chronic diseases, right? And then you have hematomas and seromas. And then you have immunosuppressive drugs, obviously. And the number one cause for infections in general, malnutrition. Remember, the first thing we said on the first page. Go back to the first page. Literally says most common immune deficiency leads to infections, malnutrition. All right. So there's that. Treatment for wound infections. Treatment for wound infections, which usually presents with erythema, warmth, and tenderness, is antibiotics, but you might need to open it if wound abscess is present. And if you're not sure if an abscess is present or not, that's when you get an ultrasound of the wound. All right. So surgical site infections within 48 hours of the procedure. So we talked about this. We're like 48 hours, like wound infections don't happen until the first 5 days, not before the first 5 days, right? No way. So if there is a wound infection and it's in the first 48 hours, that's not the first 5 days, how did this happen? There's two ways that could have happened. First of all, an injury to the bowel that led to a leak, so like basically translocation from the gut, or invasive soft tissue infection, like Clostridium perfringens. And Clostridium perfringens and Group A strep, or beta hemolytic strep, basically I remember it as gas, because they're gas forming, they present within hours post-operatively, right? And these are terrible. You do not want C. perfringens or Group A strep in the wound, like out of anything else, right? And then you have the most common infection in surgery patients is what? Anaphylaxis is the most common cause in the first 48 hours, but it's not really common. Wound infection is not that common, really. The most common infection in surgery patients overall across the board is UTIs. Because during surgery, you insert what? You insert a urinary catheter. And the most common UTIs in general, you all know this is not just for surgery, in general, is E. coli, right? And the treatment for it is simple. You just remove the urinary catheter and you give them antibiotics. And remember when we talked about, I forgot which chapter exactly, but it was like the most common cause of death, right? And I told you, whenever it says the most common cause of death, just think lungs. Just always think lungs, right? So the most common, where is it? I lost it. All right. The leading cause of infectious disease after surgery is nosocomial pneumonia, right? So nosocomial pneumonia is the most common cause of infectious death after surgery. And it's related obviously to the length of ventilation, aspiration from duodenum, thought to have a role, whatever that is. And then you have the most common organisms for ICU pneumonia, because the patient's going to go into ICU, right? Most common organisms is S. aureus, Pseudomonas, and E. coli. And honestly, just like whenever you're in doubt, just throw S. aureus. S. aureus almost never disappoints, right? And then you have gram-negative rods, number one class of organisms in ICU pneumonia. But yeah, just S. aureus is the most common as a single bacteria, but as a whole class, gram-negative rods, which include E. coli, are the most common, like number one organisms, most likely. Okay, line infections. So this was wound infections. Now let's talk about line infections. Line infections are very simple, very quick. When you think about S. epidermidis, you should think about this. You should think about line infections. And line infections include any sort of IV access, and actually just that, yeah. Any sort of IV access. So whether it's femoral lines, subclavian lines, central line placement, IVs, peripheral IVs, any of that, it's most likely S. epidermidis. Then it's S. aureus, then it's yeast. So femoral lines, just think about it. Femoral is very close to the groin area, and that's like a dirty area, right? So that's the most likely to cause an infection. And what's the least likely to cause an infection? What do people like wash a lot? Your hands, sure, but also your face, right? So just think about a clean area being like around the neck / chest, which is where you put the subclavian line. And the subclavian line is the least likely to become infected, while the femoral line, the dirty line, is the most likely to become infected, right? And if you're suspecting a line infection, just move it to another site, or pull out the central line and place peripheral IVs, right? When you don't want to risk it. You do not want to have a line infection. So if you're doubting it, if you think it might be becoming infected, just move it to a new site, or move it to another central line site, or move it completely and go with peripheral IVs. All right. So we talked about gas and C. perfringens being really bad. Like, you do not want to have these in your surgical site infection, because they're one of the causes of within 48 hours of the procedure having a surgical site infection. And it's either that or injury to the bowel. So if it's that, you want to look at it. And it usually occurs in immunocompromised patients, like DM patients, AIDS patients, or patients who have poor blood supply. So a lot of the problem with DM as well is that it causes very poor blood supply to the distal organs, or if you have peripheral vascular disease, peripheral arterial disease, this is where there's poor blood supply to that area and really high chance, or a higher chance, of getting group A strep or C. perfringens infection there, right? And it usually presents very, very, very soon after the surgery, even within hours. Like, you don't even have to wait for 48 hours, right? And the way you think about it is there's characteristic features to that, and it's usually pain out of proportion, mental status changes, and thin gray discharge. So mental status changes can be a lot of things. It could be sepsis, could be just regular stuff. When you want to think about this specifically, you want to think about pain out of proportion and thin gray discharge that is foul smelling, right? And then you can have skin blistering, you can have necrosis, induration, edema, crepitus. Also crepitus, yeah. Crepitus is very important, because remember, gas, GAS, group A strep produces gas, crepitus. Crepitus is like crackles when you press on the skin, right? All right. So necrotizing fasciitis. This is something, oh my God, terrible, right? You have beta hemolytic group A strep, so again, gas. But here, it's not C. perfringens, really, necrotizing fasciitis. It's methicillin-resistant Staphylococcus aureus, so MRSA. So if it's either gas or MRSA. And it's usually the overlying skin can be completely normal, because necrotizing fasciitis goes deep into the tissue, right? And it starts from very, very low, very below. And it starts from being like the skin could be normal. Then it turns a little bit pale and red with a little bit blistering, and you might have some gray drainage, and you might have some crepitus, and you might just a little small stuff, It doesn't really show. It's not that easy to diagnose. And the treatment for it is early debridement, obviously, because you want to get rid of all the tissue that is infected, and you want to give high dose of penicillin, okay? But it's usually polymicrobial, which means you might need to give broad spectrum antibiotics as well. So C. perfringens infection specifically, we talked about it being the necrotic tissue, low redox potential, because there's not a lot of redox is reduction, the oxidation redux potential. And this is where like basically the cells kill bacteria by using oxygen. So if there's low oxygen, C. perfringens is going to be like, yes sir, let's go. It and B. fragilis, by the way, just so you know. Because remember, B. fragilis is anaerobic, right? The important part about all of this is that it causes myonecrosis and gas gangrene. And the treatment for it is early debridement and high-dose penicillin as well. And the last type of neck fash or these kinds of soft tissue infections that are terrible is, I think this is the worst, to be honest, Fournier's gangrene. And you know, like the way I remember Fournier's gangrene is like Fournier fornication. You know, fornication is sexual relations, right? So Fournier's gangrene is in the perineal and scrotal region, right? And the risk factors for it are DM and immunocompromised state, just like the rest. And it's usually polymicrobial, so mixed organisms. And the treatment for it is early debridement, right? This is like, if you catch it, you're going to catch it late. You're going to debride a lot. When I say debride, you're going to be removing a lot of tissue. And if possible, you want to preserve the testicles, but if not, you have to remove them, right? Because it's in the scrotal and perineal area. And you also want to give, obviously, antibiotics. But it's just a lot of just tissue removed, and it smells terrible, to be completely honest with you. All right. And then you go to fungal infections, okay? So fungal infections are like this. I'm just going to give you the gist of it, right? I'm not going to give you every single point in the book. I'm going to give you what's really important. So with fungal infections, whenever you want to diagnose a fungal infection, you get the sample from the blood and you get the sample from 2 other sites as well, not just one site of blood draw that you did before. It has to be 2 other sites. And an indication for that usually is prolonged infection with antibiotics. So I've been giving antibiotics, but the infection has been the same, right? More likely that I'm giving the wrong antibiotic, especially if it's a broad spectrum, it's that it's not a bacterial infection. So this is probably a fungal infection. And in terms of fungus, you have actinomyces, you have nocardia, you have candida, and you have aspergillosis. There are 4 other ones that we'll talk about in a second that I grouped together. But let's talk about actinomyces. Actinomyces israeli is basically, it produces 2 things, right? So actinomyces, the way I remember it, by the way, all of these, just think about pulmonary always. Pulmonary is usually the default. Not all of them have pulmonary, but pulmonary is the default. I'll tell you the exceptions. So actinomyces has pulmonary symptoms, and it causes yellow granules. It usually also causes in the jaw infections causing yellow granules. But just think about yellow granules, kind of like gold, you know? And then you have nocardia. So nocardia has cardia has C in it. So besides the pulmonary, it has C and S symptoms as well. And the treatment for it is drainage and sulfonamides. Candida is the most common cause of fungemia in general, and the treatment for it, obviously, it depends on but the treatment for it is usually fluconazole. If it's severe, you want to give anidulafungin and anidulafungin, and anidulafungin is usually given in the case of ICU and CCU patients, especially ICU patients, because these are the ones with the severe infections and immunocompromised states. So if it's severe, it's anidulafungin. If it's common, if it's regular, it's fluconazole. And if it's candiduria, you also want to remove the catheter, because usually that's another cause for it, right? So actinomyces is pulmonary, it's gold. Actinomyces is israeli, so gold, yellow granules. Nocardia has cardia, C and S symptoms as well, and you want to drain it and give sulfonamides. Candida is the most common cause of fungemia. Start with fluconazole. If it's severe, like ICU patients, you want to give anidulafungin, and you want to remove the catheter if it's a candiduria. And there's finally aspergillosis. And aspergillosis usually comes after TB in the lung. So there's also lung, remember? And the treatment for it is not fluconazole. It's not fluconazole for candida, sulfonamide for nocardia. It is aspergillosis takes voriconazole, right? So there's that. All right. And then you know about the whole Americas thing, especially if you ever study steps. There's histoplasmosis, cryptococcus, there's coccidiomycosis, and there's mucormycosis. All of these are treated with amphotericin, right? Forget amphotericin B, human amphotericin, or whatever they call it in the book. They call it what? Liposomal amphotericin, doesn't matter. amphotericin for histoplasmosis, cryptococcus, coccidioidomycosis, mucormycosis. And thank God they don't ask here if it's all, like, I don't know if they ask, but probably not. Ohio River or the Florida, or I don't know, Central. I don't know, man. I don't know the states. I don't know. I'm not really. Yeah, I'm not gonna memorize all of them based on the geography. It just doesn't make sense to me, right? Not unless I go there, inshallah. All right, then you have histoplasmosis. Histoplasmosis is pulmonary. Cryptococcus is C. And remember, if there's like a prominent C, except for Candida, there's a prominent C like cryptococcus or nocardia, there's CNS symptoms. And Cryptococcus neoformans usually comes as a solitary lesion that is that presents in the brain, and it's like an AIDS defining illness, right? And then you have coccidioidomycosis, which is also, again, pulmonary. And then mucormycosis. Mucormycosis usually are found in the nose. They turn black, and they're caused by burns, or like they're higher risk with burns and trauma. But the most important part about them is that they turn black, and you have to debride these. You cannot just give antifungal or amphotericin B alone. You have to debride them as well, mucormycosis. All right, and then you have spontaneous bacterial peritonitis. All right, so SBP. There's primary and there's secondary. All right, so primary means the symptoms usually for it are mental status changes, fever, abdominal pain. Usually, in this case, it's a patient with cirrhosis, right? And a patient with cirrhosis comes with abdominal pain, and the patient with cirrhosis usually has ascites, so there is fluid already there, but it's abdominal pain and it's very tender. Like ascites is not tender; it does not hurt. But if it starts hurting, especially on palpation or percussion, or even light palpation, that's when you start thinking of spontaneous bacterial peritonitis, right? And if you're worried about it, you can tap it, right? You can take some fluid out and test it. In the case of ascites, if you test it and there's low protein, that's usually a high risk factor that this patient could have SBP or could develop SBP in the future. So if there's a low protein in the acidic fluid. Most commonly, by the way, it's monobacterial. Unlike all the soft skin infections that we were talking about, SBP is usually monobacterial and most commonly E. coli. There's also Streptococcus and Klebsiella. But remember, E. coli, gram-negative rods in the intestine, in the colon. Just think of it like that, and then you will remember E. coli is for SBP. And also, fluid cultures are negative in many cases. Peritoneal fluid. All right, so this is very important. How to diagnose it? You either get a positive culture, obviously, or you have polymorphonuclear cells more than 250,000. So not just white blood cells, polymorphonuclear cells, which are neutrophils, more than 250. Then you're like, bro, this is SBP. No way. And how you treat it is with ceftriaxone or any other third-generation cephalosporin, and you need to root out any intra-abdominal cause. So, for example, remember how we said it's tender? A bowel perforation can also present as tenderness and very similar symptoms to this. So you have to rule out that it's not bowel perforation, it's SBP as well. Also, you don't want to do a liver transplantation with a patient with active infection, obviously. And a good prophylaxis for it is norfloxacin. So remember how we said if the protein is less than 1 gram, there's a very high chance this patient can develop SBP. In that case, you want to give norfloxacin weekly, right? Weekly fluoroquinolones, specifically norfloxacin, to prevent as prophylaxis for it, right? Also, you want to give it for another case, norfloxacin, if there is active upper GI bleeds. You don't want to cause any sort of contamination. You want to prevent any sort of contamination, any sort of that, especially if it's from the GI. So you want to give norfloxacin for 7 days, right? So there's that. Secondary bacterial peritonitis is from an intra-abdominal source, usually perforated viscous, and it's usually polymicrobial, like the GI system itself, because there's perforation, and you have to do a laparotomy to find the source. Right. So HIV has a lot of things you need to cover in general, but I'm going to try to simplify it down as much as you can. So HIV exposure risk, most likely it's from HIV blood transfusions, right? And then you have infant from a positive mother, you have needle stick, you have seroconversion, which is very unlikely. And the treatment, the mucous membranes is very unlikely, but the seroconversion usually takes 6 to 12 hours, so you can test an HIV patient and he can be seronegative if it's right after. But if a patient, for example, gets an HIV blood transfusion and you know this is HIV positive blood afterwards, obviously not during, you have to give AZT, which is zidovudine, which is a reverse transcriptase inhibitor. It doesn't matter. Just remember, treatment for HIV, AZD and ritonavir, right? AZD and ritonavir. Anything that has avir unit usually is good, antiviral, right? And you want to give it within 1 to 2 hours after exposure. So very, very soon after exposure. So opportunistic infections, as we talked about previously, CMV is the most common, the most common indication for laparotomy in patients with HIV is CMV, right? And then the second most common indication for patients with HIV to have a laparotomy is neoplastic disease, so lymphomas, right? So it's either CMV or lymphoma. CMV colitis is the most common intestinal manifestation of AIDS, and Kaposi sarcoma is the most common neoplasm in AIDS. Because remember, it's CMV or lymphoma slash any type of tumor, but it's lymphoma slash Kaposi sarcoma. So Kaposi sarcoma is the most common neoplasm in patients with HIV, but it doesn't need surgery. But the most common cause for surgery in HIV, our second most common cause after CMV colitis, is lymphomas, specifically stomach lymphomas, right? So malt lymphomas, these are the ones we're talking about. And it could be malt or it could be non-Hodgkin's B cell. And you want to give chemotherapy, obviously, but you might need to do surgery, all that stuff. GI bleeds. Okay, so this is important as well. So GI bleeds in patients with HIV patients. We talked about the indications for laparotomy. We talked about the most common intestinal manifestation, the most common neoplasm. All that's good. Let's talk about the GI bleed. So if it's a lower GI bleed, it's going to be CMV or bacterial or HSV. But remember, lower GI bleed, CMV. Upper GI bleed, Kaposi sarcoma or lymphoma. And remember, CMV is the most common overall, which means lower GI bleeds are more common than upper GI bleeds, because CMV is more common than lymphomas and Kaposi sarcomas. And you want to give antibiotics starting around 250 to 250 CD4 counts in the case of HIV, because less than 200 is when opportunistic infections just take over the place, right? Right, and I'm looking, we're almost done. We're going to talk about a little bit about hepatitis C very quickly, 2 lines, and then CMV, a couple of notes, and then other infections, we're just going to run through them. You know this stuff, right? Okay. Common knowledge. Let's go. General knowledge. Hepatitis C, right? Hepatitis C is it's a chronic infection, and it causes cirrhosis in 15% of the patients, causes HCC, hepatocellular carcinoma, in 1 to 5% of the patients. It's kind of high, not gonna lie. And then it is the most common indication for liver transplantation, right? Hepatitis C is the most common indication. And now it can be cured with Sovaldi, which is sofosbuvir, as well as ribavirin. Ribavirin can be given for HIV, remember that. Oh no, actually, ritonavir is given for HIV. Don't remember that. Anyways, so Sova and sofosbuvir and ribavirin can be given, but don't remember that. It's not very important. Just remember, it's the most common cause, the most common indication for liver transplantation. Right. CMV infections. We said are the most common indication for laparotomies. They are the most common cause of lower GI bleeds, which are more common than upper GI bleeds in HIV patients. All of this, by the way, in the HIV patients. And they're transmitted through leukocytes, right? And the most common infection in transplant, they are the most common infection in transplant patients. So any sort of transplant patient, you do not want to give them, you want to give them CMV free blood. Like, you want to give them blood that is tested for CMV. Make sure it's negative, because if it's the most common infection in patients with transplants. I don't know why I remember especially kidney transplants, but I think overall transplant. The most common manifestation for it regularly, the one that's like, it's fine, is febrile mono, right? Remember, we talked about it. Mononucleosis usually causes sore throats, adenopathy, all that kind of stuff. You just don't want to, with mono, you do not want to play sports for I think 2 weeks or something like that, or maybe 6 weeks, because there's a high chance of spleen rupture. Besides that, you're all good. It's not that big of an infection. But the most deadly form of CMV infections is what? Has to do with which organ, as per usual? CMV pneumonitis, right? So CMV pneumonitis is the most deadly form of CMV infections. And the diagnosis for it is you take a biopsy of wherever it is, and it shows a characteristic cellular inclusion bodies. It's kind of like the owl eyes, very similar to Hodgkin's lymphoma. It's it has cellular inclusion bodies right inside it. And the treatment for it is Janciclovir. You can obviously give CMV immunoglobulins for severe infections or CMV negative patients receiving CMV positive organ. But in general, you want to give Janciclovir, right? That's the regular treatment. All right, here's some for like, this is, I feel like this part, the other infections part, is literally just a trivia, right? So aspiration pneumonia, what is the most common, which segment is the most common? The superior segment of the right lower lobe. Which is the most common organism? Aspiration pneumonia, you might think, oh, anaerobes. But the most common organism is strep pneumo. After that come anaerobes. All right. High sensitivity for osteomyelitis. How do you test for osteomyelitis? Do you take an X-ray? Do you take an ultrasound? What do you do? MRI. Okay. Here is two kinds of spiders, right? You have the brown recluse spider, and then you have the, where is it? There's another one. I think it's the black spider. All right, let's just talk about the brown one for now. I think it's another place, all right? So the brown recluse spider, because he's brown, you want to dap him up, right? So dapsone. You want to give dapsone to the brown recluse spider. And the problem with the brown recluse spider is that it causes necrosis, right? It causes necrosis, and you give them dapsone. I will talk about the black one later. I remembered where it is. Anyways, acute septic arthritis, right? Acute septic arthritis most commonly is S. aureus. Second most common is gonococcus. So there's that. There's also H. influenza and strep, not really important. Just remember, Staph aureus is the most common. And the treatment for it is to drain. What don't you drain? Hemarthrosis from hemophilia A. If you remember that. You do not drain those. You do not tap those. You do not touch them. You just ice them and you give them exercises, and then you're like, hey man, this will be fine on its own. But if it's acute septic arthritis, you want to drain it, and you want to give third generation cephalosporin or vancomycin, preferably vancomycin, because it also covers MRSA, right? Diabetic foot infections is usually mixed like everything, and you want to give them broad spectrum antibiotics, right? Cat, dog, human bites, the most common is strep pyogenes, but in general for humans specifically, it's Echinella, right? And it can cause permanent joint injury, but remember, humans, Echinella, cats and dogs, Pasteurella. So Pasteurella multocida is for cats and dogs, Echinella is for humans, and you want to give them augmentin, broad spectrum antibiotics for those, right? So impetigo, erysipelas, cellulitis, and folliculitis. So remember, cellulitis most common is S. aureus, erysipelas is S. epidermis, but it doesn't matter. All of these, staph is the most common, and then strep. Right, so furuncles and carbuncles. Carbuncles are just some like multiloculated furuncles. Furuncles are usually boils. They're boils, and they are either S. epidermis or S. aureus, as we said, and you need to drain them as well as give antibiotics. Peritoneal dialysis catheter. Symptoms that's catheter infection. If you have a peritoneal dialysis catheter and it becomes infected, it will likely have cloudy fluid. So you want to check that. As well as abdominal pain, fever, and the most common one is S. epidermidis. Remember how we said any sort of line, the most common is S. epidermidis, right? So this is a peritoneal dialysis catheter, S. epidermidis. Central line, S. epidermidis. That kind of stuff. All right. Treatment is intraperitoneal vancomycin and gentamicin, and you want to remove it for peritonitis that lasts for 4 to 5 days at least. Right? You want to remove the catheter. Sinusitis, it's either nasoenteric tubes, intubation, facial fractures. If you do a CT for the head and there's air fluid levels in the sinus, you want to give them antibiotics, and in rare cases you have to tap the sinus percutaneously for systemic illnesses, right? Lastly, we talk about the prevention of nosocomial infections. Number one is hand washing, right? And who's the highest risk patient for that, for any sort of nosocomial infection? Burn patients, right? Because that first line of defense to the skin is gone. And obviously in isolation, you want to leave the gowns and gloves, but most importantly, number one, hand washing. And to prevent surgical site infections overall, you want to use clippers instead of razors, remember, because you want to shave the site. You don't use razors, you use clippers. And you keep the glucose from 80 to 120. Remember, there's another one we were talking about, I think it was sepsis, and you have to keep the glucose less than 160 or 180, I believe. But in the case of surgical site infections, you want to keep the glucose between 80 and 120, so very tightly controlled. You want to give them good oxygenation, and you want to keep them warm. And you want to clean with chlorhexidine prep with iodine impregnated drapes. And that is the infection.